My name is Emily Bucholz. I'm an assistant professor and a pediatric cardiologist who specializes primarily fetal cardiology down at the University of Colorado and Children's Hospital Colorado. My interest in heterotaxy began during my training with Dr. Shidlow, where I had the privilege of working with the Heterotaxy Registry in Boston, and have subsequently kind of done additional work on existing registries through a role that I serve for the Pediatric Heart Network through the Data Science Committee. My talk today, if I can pull it up. Was to share my experience on leveraging existing registries for heterotaxy research. So I'm going to be talking about turning data into discovery, harnessing registries to transform heterotaxy research. I'm going to caveat this talk. I don't have any disclosures, but would welcome some if other people have ideas. But I'm going to preface this talk with a caveat that I'm a pediatric cardiologist, as I just mentioned, and so my knowledge is mostly of cardiovascular registries. There are undoubtedly other registries in other fields that I'm not going to touch on today. So the goals for today will be to recognize challenges in conducting heterotaxy research. We just had a great overview by Dr. Spurgeon. And then we'll review existing registry opportunities, talk about some limitations of those existing registries, and then explore a little bit about approaches that we might be able to mobilize or to further leverage existing registries as a community. So I'm not going to belabor this because, again, we saw a better graph by Dr. Spurgeon just briefly, but I just wanted to kind of show that, as Dr. Spurgeon mentioned, we are increasing in the number of heterotaxy publications by year, but that the kind of global number still remains low in the overall composite of medical research. So why have we had trouble increasing that body of research? Well, there are several challenges, as we all know, when it comes to studying heterotaxy. First, heterotaxy is a rare disease. The quoted incidence of heterotaxy is around 1 in 10,000 live births, or approximately 3% of all congenital heart disease. So most institutions in the U.S. will see between 10 to 25 babies maybe a year, which limits the interpretability of single-center studies. Second, as we all know, there is considerable heterogeneity in anatomic phenotypes and management strategies. Because the cardiac and extracardiac disease and heterotaxy can be so varied, it can be really hard to study clinical traits or to make sense of outcomes across patient subgroups. And then finally, there is a significant amount of institutional variation, both in the surgical and clinical management, so that findings at one center may not be generalizable to other centers. And these challenges all point to the limited utility of kind of single center studies and understanding both the presentation and the outcomes in this population. So registries, on the other hand, are powerful platforms for leveraging cross-institutional collaborations, both to increase numbers and power, and also to help us standardize terminology when we're working in the research area domain. But before we dive into a few of the cardiovascular registries, I want to take a moment to just review other types of multi-center public data sets. So I like to break these down into the following categories based on the type of the data that's collected or the auspices under which those data were collected. So specifically, I think of data sets in 3 categories. There's administrative claims, there's clinical registries, and then there's secondary use data sets. And we'll run through a couple of examples on the next few slides. So administrative claims data sets, as we all know, comes from billing and payment side of healthcare. So every time a patient has an encounter, a claim is submitted to the insurer for reimbursement. And depending on the data set, these claims can include information on diagnoses, procedures, medications, hospitalizations, and costs. They're great because they often cover large, diverse populations over long periods of time. They're often linkable, but they can be defined by specific age groups or also locations of care. So a few kind of prime examples include the AHRQ HCUP data sets, the Pediatric Health Information Systems data set run by the Children's Hospital Administration. And then there's a couple of kind of very large data sets that are run by specific insurers like Medicaid, TAF, or some of the private payer databases. These data sets undoubtedly capture patients with heterotaxy, but because the data are not collected for research, the variables can be imprecise and can also be variable across sites. Clinical data can obviously be limited because we're capturing claims, and then the data sets can be limited to specific instances of care like inpatient admissions, and longitudinal follow-up data can therefore be limited. So Overall, these are great data sets for understanding patterns of care and outcomes at scale, but they often lack the clinical detail that we need or that we would find in a medical record or registry. On the other end of the spectrum is secondary use data sets. So these are data sets that were usually collected for a specific clinical trial to test a particular drug or intervention, but can then be later repurposed to answer new research questions. Because trials collect detailed, really high-quality clinical and outcome data under standardized protocols, they can be really valuable beyond their original intent. But the challenge is that the populations are often highly selective, and so there may only be a few patients with heterotaxy in these data sets. As an example, in one of the largest trials in pediatric cardiology, the Pediatric Heart Network's single ventricle reconstruction trial, there were only 38 patients out of 549 that had heterotaxy. So you can imagine a subgroup analysis of that trial may yield limited insights. And then finally, clinical registries, which is the focus of this talk. So clinical registries, as the name implies, are organized systems that collect detailed clinical information about groups of patients. They can be defined by specific conditions, settings, outcomes. A few examples are STS, PC4, PAC3. All of those collect data on patients undergoing cardiac surgery or who are admitted to the CICU or to other step-down units. NPC-QIC and the Fontan Outcomes Network collect data on patients with single ventricle heart disease. And then PCGC and CNOC are defined by the type of data that they collect. So in this case, genetic and neurodevelopmental data. Unlike claims data, registries are built usually for quality improvement in research, so they tend to have rich clinical data and standardized data elements across sites. They're really great for understanding real-world outcomes, practice variation, longitudinal trends. But the flip side is that participation is often involuntary, and the data collection can be labor-intensive. So sometimes completeness and representativeness can still vary. But when they're done well, registries are one of the most powerful tools we have for studying rare or complex diseases because they often span quite a few centers. I want to spend the next couple of slides just giving you a flavor of some of the registries that are available. Again, this is not meant to be comprehensive, but to discuss how these registries are defined, what data are collected, and then what types of opportunities might exist for us to leverage them. So again, these are going to be brief. STS-CHSD, that's the National Congenital Heart Surgery Database that's run by the Society of Thoracic Surgeons. It includes all patients with congenital heart surgery at participating centers. There's now 118 centers that are involved. Centers send information on cardiac anatomy and procedures, inpatient complications, and in-hospital and 30-day outcomes to the STS, which then uses them for public reporting and generating comparative data for sites across the country. So the data can be quite rich, but they can be really hard to access as well outside of the STS. PC4 and PAC3 are two other cardiovascular registries that are defined by where they admit patients. So PC4 focuses on patients under the care of the cardiac ICU team, whereas PAC3 includes all medical and surgical patients admitted to non-ICU cardiology services. So PC4 was started in 2014, PAC3 followed a year later. Again, data are quite rich, but they're limited in this case to inpatient data only. Notably, I'll just mention that all three of these data sets are quite easily linkable because they're all recorded in the same interface, which is CardioAccess. There's also a series of national registries for patients with single ventricle heart disease. So the NPC-QIC, or the National Pediatric Cardiology Quality Improvement Collaborative, includes all patients with hypoplastic left heart variants who underwent a Norwood procedure in the neonatal period, and includes clinical details and outcomes through the first year of life. The Fontan Outcomes Network includes patients with both hypoplastic left and hypoplastic right heart who have undergone the Fontan procedure, and in theory could follow these patients lifelong unless they change institutions. Notably, the NPC-QIC and FON are currently in the process of merging and transitioning to a new data set, which is going to be termed SV1. And in fact, they're actually having their national meeting in Indianapolis this weekend while we're here. For all of these registries, there's about 60 centers that contribute nationally. And then finally, as I mentioned, there's a few data sets that are defined by the types of data they collect. So the PCGC is a consortium of 8 centers currently, although there's been some ins and outs of institutions as they've kind of gone in and out of contributing data. But they consent patients with structural heart disease. into a registry where they will then collect patient and parent trios in addition to 5-year outcomes. CNOC is I think they're currently up to about 52 centers and includes all patients with heart disease who are undergoing comprehensive neurodevelopmental testing at those centers. And then finally, I'll mention the one non-cardiovascular registry here, which is the PCD Foundation database, which includes all patients with a diagnosis of primary ciliary dyskinesia. And this data set does include diagnostic testing for PCD. So what has been published from these registries? The short answer is not a lot. There's been a few studies, either explicitly studying patients with heterotaxy or that have included heterotaxy as a subgroup, but they are quite sparse from these registries. Of the recent publications, the largest subgroups of heterotaxy patients that I couldn't find included 270 patients in PCGC and 44 patients in NPC-QIC. So you can imagine, again, our insights are quite limited, even in some of these, because we're dealing with relatively small numbers for some of the more focused data sets. However, there have not been any studies that I could find from STS, from PC4, or from PAC3 that focused on heterotaxy specifically. And these data sets are the ones that cast the broadest net by including all patients with structural heart disease. But for as much promise as these registries hold, they also have several limitations. So first, and most obviously, they are not specifically focused on patients with heterotaxy. And so as a result, they often include low numbers of patients with heterotaxy and may include only specific subgroups, like patients with single ventricle heart disease. Second, they are often organ-specific registries. So I spoke mostly about the cardiovascular registries, but the PCD Foundation registry is specifically focused on pulmonary disease, primary ciliary dyskinesia. And because they are often organ-specific, they usually contain limited data on other organ systems. And then third, there's the potential for survivorship bias in many of these registries. So what do I mean by that? Registries like FON, so the Fontaine Outcomes Network, CNOC, PCGC, they're not birth cohorts. And so they only include patients who have survived long enough to have undergone a Fontaine or received neurodevelopmental testing. And because of this, we risk missing out on an important high-risk population, the neonatal population who may not survive to that point. And the results from those studies that use those registries may not be generalizable to the broader heterotaxy population. Fourth, these registries do not collect detailed anatomic data, cardiac or extracardiac. They tend to use kind of our classic groupings of cardiac diagnoses rather than systematically entering data on segmental anatomy. Diagnostic and management strategies are usually incompletely captured in these registries. It's not always obvious which diagnoses a patient was screened for, and many of the procedural and extracardiac diagnoses come from ICD codes. And then finally, these registries usually follow patients for a finite amount of time, like hospital discharge, or occasionally up to a year or two, but long-term follow-up is virtually unheard of. And yet, despite these limitations, there are important questions that can still be answered by these registries. So specifically, questions about incidence or prevalence of phenotypes, predictors of outcomes, trends in incidence or outcomes, and then identification of genetic contributors or common types of questions that might be well suited for these types of registries. And these questions can be answered globally or, again, for specific subgroups like single ventricle heart disease or the patients with arrhythmias or heart block. But there are ways that we can extend these insights to increase the power of registries even further. So up until now, most of the data from registries has come from single registries. But the truth is that many of these patients are obviously included in multiple registries. So there have been success stories of linking registries. A classic example is CNOC and the PAC3 or PC4 registry. And the benefits are obvious. You get more clinical data or greater diversity of outcomes that you can study. But the limitation is that you often end up with subsets of patients that cannot be linked. And so you might end up with even fewer patients than when you started. Several strategies for linking have been either used or proposed. So the most common way we do this is through probabilistic matching, which involves the use of a few key patient identifiers, things like name, birth date, center, to ensure that you're identifying the correct matches across registries. And while this may seem obvious, it turns out that even our pediatric patients change their names and that humans are prone to typing errors. And so sometimes we don't get matches even when we try. Another strategy that's been trialed is local matching and reaggregation, where individual centers will pull down their registry data, they'll link it to other data locally, and then they'll re-upload it so that it can be reaggregated with other centers. And this strategy has been particularly helpful in scenarios where data permissions are challenging or the registries don't use or maintain patient identifiers. And then finally, I'll just mention GUIDs, or Global Unique Identifiers, which have been discussed as a future strategy in pediatrics to facilitate linkages more easily. The concept is simple: assign every patient a unique encrypted identifier, but it's proven much harder to implement in practice. I'm happy to talk to anybody about those because we've gotten deep in those discussions recently. Beyond existing registries, there may also be opportunities to link registries to non-registry data sets. So examples might include the National Death Index, the Pediatric Health Information Systems, or FIS, or any of the payer data sets. Again, the advantage is extended follow-up because these claims databases capture longitudinal data up until the patient exits the plan or transitions to another hospital. And the same linking strategies apply to this type of linkage. And then finally, it can be possible to link the registry data that's at your center to data that you then enter to local data that you have. So this could include things like imaging data, additional genetic or multi-omic data, prenatal or environmental data that's not captured in the registry. And the obvious benefit is, once again, increased depth and richness to the data. Practically, this can be challenging because you need to ensure that there's adequate overlap of your data set with the registry data. And my experience has been that investigators usually opt for the path of least resistance, which is just to collect their own follow-up data so that they can define the variables they want. But in theory, this is a practice that could be done to kind of limit the amount of data collection for your own studies. So where does that leave us? So on the next few slides, I'm going to try to pitch an idea for how we might leverage our own registry data to create a heterotaxy data hub, and I'll explain what I mean by that in a second. So what if we were to establish a consortium of hospitals that were willing to identify their own heterotaxy patients locally? We could ask those hospitals to create local copies of their own registry data for those heterotaxy patients and then link them wherever there were matches across data sets. This isn't hard to do. We could then combine the linked registry data with additional data that was collected from the medical record, and that could be brief, but we could essentially define anatomic variables or diagnostic and management strategies that would be identified or defined by the HRC3 consortium. All of this abstraction and linkage would need to be done locally, but again, it would kind of decrease the amount of data burden collection, or the amount of burden of collecting these data, because we were going to be linking to additional registry data. And then finally, we would ask those hospitals to share their de-identified data in a central repository of heterotaxy patients. And so by bringing together data from multiple hospitals, we'd finally have enough patients to start asking meaningful questions, or at least that would be the hope. Not just about survival, but about anatomy, management strategies, and outcomes across the full spectrum of heterotaxy. We could identify patterns that individual centers aren't powered to see on their own, and it would allow us to link registry data to real-world anatomic and clinical data to get a more complete picture of each patient. I think this type of data set, or this type of data hub, could transform heterotaxy research and kind of make it a little bit more tangible for centers who don't have the ability to do detailed abstraction at their own centers. I've included a few ideas of what types of data would need to be locally abstracted versus what could be pulled directly from the registries. So locally abstracted data elements would be, again, kind of detailed cardiac and extracardiac anatomic data, segmental anatomy, diagnostic testing, and then therapeutic or management strategies. But the data that we could leverage or harness from existing registries would be things like cardiac surgical procedures, perioperative management and course, genetic data, potentially neurodevelopmental outcomes, and in-hospital or longitudinal outcome data. But most importantly, I think a heterotaxy data hub shared nationally across heterotaxy centers would also allow us to link even more data and to start to forge research collaborations across centers to gather the other types of data sets for linkage. So here I'm thinking again about imaging, genetic, multi-omic, prenatal, environmental, social terms of health, neurocognitive, or other types of patient-reported outcome data. And you could think of these almost as like ancillary studies for the hub, where people could essentially propose or bring some additional funding in to collect these data and then link to the Heterotaxy Data Hub. So I'll leave you with this. I know we have several conversations happening this afternoon, and we can think a little bit more about how something like this or other types of ideas for creating a national heterotaxy registry could be performed. But registries offer a powerful infrastructure for accelerating heterotaxy research, but obviously each has its own limitations. I think future progress hinges on collaborations across centers to start to harmonize and creatively leverage existing data. And then finally, efforts that combine heterotaxy-specific data elements that are collected locally with structured registry data, I think, are the most likely to succeed. So thank you.